You gotta spend some time. Oop, there we go.
Sorry, Eric.
That's all right. Got to spend some time working on that. As far as the radial head goes, the biggest thing that I have, and I talked about it a bit during the course, was just doing that kind of slow, controlled, eccentric pronation, supination with something that has some sort of weight to it. So, I mean, we talked about a hammer, a baseball bat for a thrower is probably just as easy to get a hold of. That'd probably be some of the major things that I'd look for. Um, you can have them do some kind of bent elbow upper extremity weight bearing. It doesn't want you don't want it to be excessive early on when they're dealing with recovery from an abducted ulna. But I'm thinking, you get a high-low table or one of the treatment tables about waist height, and then you want the elbows, kind of down by their sides so that they're kind of leaning on with their palms facing away from them. And that sort of stuff, if you do just kind of some weight shifting, should help them be able to figure out um, kind of proprioceptively where that radial head needs to be in relativity to the capitulum. So I think that's something else that you can do. But other than that, I mean, the biggest thing you can do for a kid that comes in, especially a thrower that comes in with an abducted ulna, is figure out why it abducted on its in the first place. So, barring this person having some sort of fall on an outstretched hand, it's likely due to lack of mobility either in the shoulder girdle, or upper thoracic region, so that CT junction area. And that's why they're starting to develop more of that abduction force going through the elbow as they're going through the pitching motion. Anything you want to add there, Dave?
Now that, and as we get into it later on, it's going to be looking at the biomechanics throughout the body. Like you need to look at the whole system now because you now have all the pieces. So you start to think about what is accelerating the forces at the elbow. What are the components from foot position, hip to thorax that would also create the torque in the elbow as we do this. So if he has video of him throwing, you don't have to be, it helps if you have familiarity with throwing, but you don't necessarily need to. I find I can look at videos of a sport and I can basically surmise what is going to be kind of acceptable range and ratios and see it. So you should be able to review that kind of quickly and say, okay, what is normal throwing mechanics? What is, where is he building up the stresses? So if he has a video of him doing a sport, have him give you the video copy and take a look at it. That way you get a couple of days to kind of assimilate. You can look at his video, you can look at Norm's, and you'll quickly see where he's off.
Yeah, and it's problematic because you don't want to start looking at yourself as like a pitching coach, right? As somebody
Correct.
that's like a throwing coach necessarily. I mean, I guess if you have some expertise in it, if you've been a thrower,
Hmm.
and you'd had some mechanical training from another expert at some point along the line,
Hmm.
that's probably fine to kind of take some of those liberties. Um, but things like arm slot play a big role with pitchers. So, I mean, in theory, you
Hmm.
should have the arm kind of either in a 90-degree angle or even maybe less when they're going through that kind of late cocking phase. Um, but what we see a lot of times is if they start to develop some restriction, as they start to lean this way, the elbow gets a little more straight. And so their arm slot ends up being a little wider than what they're typically used to. And that's obviously a position where you're depending more on some of that bony articulation between the olecranon fossa and the trochlea to kind of maintain stability in that position. And that's just not ideal, right? When we're here, we have much more. We start talking about that coronoid process being articulated. We start talking about the posterior band of the UCL being a component of that starts to play a role. So there's a lot of little factors that play into the whole situation there. But yeah, I mean, Dave's totally right. If you can get some video of him going through his process, and depending on where they're at in their age group, if it's high school, even college and whatnot, there's likely to be video somewhere out there that they're going to be carting around with them. So it's possible. Did you give him something specific, or was there?
Yeah, I mean, I haven't looked at the video. He had a ring lesion in his upper thoracic, so I manipulated that today too.
Nice.
And that's been going well. He doesn't have any pain. He was getting some ulnar symptoms. The only
Yeah.
thing I gave him like elbow quadrants at first, after I had maniped his ulna, and then gave him like a right look over for his CT junction because I found that the first day too. And then I didn't do the annular, I don't know what you call it, but when you're on the elbow, the one that you showed us. I
Yeah,
didn't do that.
the approximation.
The
Right.
approximation. Okay.
Approximation of the radial head.
Okay. So I did that today, and that seemed to be good. And then I just did some, I activated flexion and extension. I didn't do it slowly though. It's not flexion and extension. Pronation, supination. I just didn't do it slowly. I just had like a TheraBar, so I was just having him do that after I had manipped him. But I'll incorporate the slow eccentrics next time too.
Yeah, and there's a process to it, right? So the eccentric stuff is just building up better recruitment. It tends to be better for the loading mechanism and for the kind of the collagen makeup of some of the like the tendon body, the tenoperiosteal junction, and then all of the ligamentous structure. So that's been pretty well documented in the literature, not just in throwers, but also in like weightlifters and whatnot, that if they want to kind of maintain healthy joints, you have to be able to take the joints through, full excursions of motion. So even under load, right? And so that's part of that. But eventually, um, the speed of the resistance has to accelerate a little bit, right? Because this player is still going to have to be able to generate this acceleration. And so the tissue has to be capable of tolerating that. And so you can kind of build in a little bit over time, right? This isn't something that you do in the first, even week or two. Once you get them pain-free and you get the mechanics cleaned up and everything's looking pretty well with that, then you can start building in, more of a true plyometric type of routine with it to kind of get the tissue used to that stress as well. It's kind of similar to like, having a runner do a little bit of jumping and bounding and things like that before you send them out to do any actual runnings. You need to make sure that the tissue is capable of tolerating that higher, that more ballistic load after a certain amount of time.
Okay, sounds good. Thank you.
Yeah, no problem.
Yeah, and the best thing too is, I'll defer on that because he's right. Like I'll work with people and say, listen, I can identify the problem. Here's where we need to look at. It's somewhere your lower extremity mechanic. Do you know what? Hey, who's the pitching coach you work with? Throwing coach you work with? Oh, you don't have someone? Hey, here's what I recommend. You need to do at least one session with Jim, who I know or found, and then do a session with him. It's gonna be good. He's gonna clean this up. We're gonna tell him what we're looking for, what I think I see, and let him take a look at you. Because as much as I get the biomechanics of what's doing it, you see a pro and they really help fine tune it. And not only will it make you, kind of take away some of your problems, it's actually going to improve your throwing. And that's exactly how I sell them on doing that. It takes some of the onus off of me to get 100% of the mechanic, and the buy-in on that is always very good. So you get somebody who's throwing like that, it's a
Yeah.
really good thing. And if you're sending people to a pitching coach or something like that, guess who he's likely to send the people back to.
Yeah, I was just gonna say that becomes a nice working relationship too. It's just like, well, I have this thrower, he's not, hasn't been working with anybody, but I think there's some mechanical things here that, he might benefit from a couple of sessions, and then all of a sudden they get somebody that's just like, oh, you know what, I'm starting to have this discomfort. It's like, well, shit, I got the guy, and Joey's the guy. We'll send him out. We'll send him out to see him. So that's a nice little perk when you have something like that going as well. So,
Yeah.
what else we have? Anything else? Sounds like a couple of good tib fib treatments going on. That's a good sign. I like the sound of that. What were the symptoms you guys were seeing? Mitch, Courtney, when you saw the tib fib stuff?
Uh, for me, it was. Well, man, I'm letting my dogs out. But what's
Yeah.
going? For me, it was I had a kid who's about 6'2", 280, and he couldn't really do a squat without having pain, getting into like the lower position. And so I think previously to the weekend, he came in, and I was like, well, I know what's going on. I didn't know how to fix it, so that was kind of fun. And then we came back. He felt all right, and then I was able to give him a nice little manip, and he moved perfectly fine, no pain with either with any direction or squat or even the rotation like we worked on that weekend.
Mhm. Nice. Did you say 6'2", 280?
Yeah, and he's like a sophomore in high school.
Dear God.
He's a massive kid.
No kidding. That's a giant. That's a massive adult, not just kid.
He's
Hmm.
the starting right tackle at like the local big school. I don't remember what school it is, but
Gotcha. Well, cool. Well, that's good. What about you, Courtney? What are they dealing with?
I had a gentleman who had a meniscectomy, and his pain was anterior lateral knee and upper leg pain.
Mm-hmm.
And he came in after the surgery and he's like, it's still there. It didn't solve anything. So
Hmm.
he was stuck anterior lateral and I moved it and he's like, it's completely gone.
Wow,
I was like,
nice.
well, I'm sorry you had surgery, but I'm glad the pain's gone.
That's an interesting one because that's something that we probably would have gotten into if we were able to clean up the whole knee stuff during the weekend. But when you have anterolateral knee pain, as far as the hypotheses that you can have, what's causing it, it's a relatively short list. We deal with joint line pain that's probably more likely related to the coronary ligaments, which are they're kind of the circular, semicircular type of ligaments that hold the meniscus to the tibia. They're supposed to be mobile, so there's supposed to be some movement in there that allows the meniscus to kind of glide with independent of the tibia so that it doesn't get kind of crushed into paste by the femoral condyles. Um, so those can certainly be painful. That ligament itself can be painful. It's right along the joint line, which I think is probably a lot of the reason why, um, one of the quote unquote gold standard methods of figuring out if there's a meniscus tear is joint line tenderness, right? And it's just like, well, is it really the meniscus? Probably not, because the meniscus itself doesn't often have a lot of nociceptors in it, right? It's not really capable of producing pain. The ligaments, however, do, and they do kind
Yeah.
of blend into the meniscus, the kind of the peripheral portions of the meniscus. So that's where I think most of the pain response actually comes from, is more from the ligament structure than it is from the actual meniscus. So there's that. Fibular head, that's probably another one of the major ones. You probably look at, maybe a little bit of LCL, maybe a little bit of kind of the anterior fibers of the TFL or sorry, the IT band coming down from the TFL. So the possibilities get to be really slim. So the good news about it is most of those areas, most of those structures are very available for palpation, right? So you can feel the anterior joint line of the tib-fib joint. If it reproduces their discomfort, you're feeling pretty confident that's what's doing it. If you can get a good digital pressure on the coronary ligaments just by palpating the joint line. Basically, kind of get a thumb in there and then you press down and then you will friction across that. If that reproduces the pain, another pretty good sign that you're onto the right thing. IT band, LCL, those structures, they're all very palpable. So, and that's probably the best mechanism. I mean, we can do some other things to try and stress these tissues, but there's nothing that's more specific than just getting your finger on something that's sore and seeing if it reproduces their pain. So, the tib fib one is a good thought, and it sounds like you got a good correction out of it, and it worked. The coronary ligament is something that tends to be problematic if there's a problem further down the chain. So the one that tends to be almost universal for the lateral coronary ligament is a loss of subtalar eversion. So you lose the ability to evert the heel. It's a horizontal joint. It's a rotational joint. Um, the next horizontal joint realistically in the chain that produces that same sort of rotation is the knee joint, the tibiofemoral joint. So we see a lot of that sort of stuff, and we'll go over more of the mechanics on why that gets so irritable as a result of that, when we talk about some of the stride stuff and some of the components in module 5 here coming up. But that's a pretty consistent problem that we run into is those coronary ligaments.
So Eric, if I want to look at this, I have this guy coming in tonight.
Mhm.
If I want to look at the coronary ligament, you said you just go into the joint line,
Yeah.
and you can just like push straight into it and it'll
Well, so
like,
like if if this here is the joint line, right?
Uh-huh.
What you want to do is you just want to get a finger in between, press down toward the tibial plateau.
Yeah.
Um, what I would do is I'd put the knee in kind of that hook lying position, about 90 degrees of knee flexion, and then you want to internally rotate the tibia.
Okay.
Okay, so if you internally rotate the tibia, right? So here's our knee. If we internally rotate it, the lateral compartment of the knee will become more prominent anteriorly.
Mm-hmm.
Okay, so that's going to give you a little more space to get digital pressure on that ligaments. And literally, it's just press into the negative space between the tibia and the femur, and then press down onto the tibial plateau, and just kind of work your way around. Because the irritation can be limited to, a handful of fibers or, a certain region um, of that ligament. And so it's just, you got to kind of poke your way around until you get toward, basically from the patellar tendon around laterally until you get toward where the um, fibers of the IT band are starting to come across the knee. But if
Okay.
that's painful, the first thing that you do immediately is you go down and you check mobility of the subtalar joint, because odds are it's.
Okay. Okay. Awesome. Thank you.
Mhm. That's a fun one. It's very easy to fix. Sesamoid fracture. Jacob's feeling it now. He's finding all kinds of cool stuff. Tell us a little about that one. Just did it today?
It was earlier this week, Monday or Tuesday, and it was electric scooter injury. So
Those never happen.
yeah, so he came in about a month out, and that sesamoid is super tender, does not glide at all. So we did a little bit of that and kind of worked on some passive mobility, but he's getting some ankle like stiffness pain, if that makes sense.
Sure.
He was in a boot for a while and didn't have any loading of it because he was in a cam boot as well.
Gotcha.
But doing some extra history towards the end of the session, he mentioned he sprained that ankle a bunch. So I decided to look at his posterior drawer test, and of course it was positive.
Yeah,
So
gotcha.
did that the taping technique. So I see him later today. So it'll be interesting to see how he feels with all that. But
Yeah,
yeah,
that's good. Did he have do you have a traumatic arthritis of the big toe as well when he damaged the sesamoid?
yeah,
Yeah. So there's at least there's some things that you can kind of do there to kind of get that going.
But I thought it was interesting. His podiatrist said he cannot do any jumping for about 6 months, which I thought was interesting because for a fracture like that, I thought once you kind of heal it, you could probably start progressing as tolerated. But I don't know.
Mhm. That is interesting. Let me think about that for a second. What do you have any ideas there, Dave, on what that for 6 months? I know you're muted here, but you got yourself muted.
Is it because of the tearing of the lateral ligament? Is it the fracture? Is it just his personal bias? Because so much of what people were told many times by professionals is just a glib, oh, when can I do this? Oh, don't jump for 6 months. But is that based on personal opinion or is that based on data? That's the portion of it there that you may not know. In how often somebody go to an orthopedist, they tell them they're wear a brace for a period of time, then they go back the next time and they change the time. You
Yeah,
know,
I can't see, I mean, from a time frame perspective, I can't really think
Mhm.
of anything that would make me think 6 months is kind of the standard, because I'm thinking, vascularity, so you don't get a necrotic sesamoid. Thinking, structurally with
Mhm.
the ligament tear, are we thinking friction from all of that once the bone is healed should be in pretty good shape? I mean, I guess, maybe the vascularity thing is a component, but 6 months seems awfully long.
And I'm sorry, I missed the age of the person.
He's 43. So he's 43,
Good
and
age.
he was also instructed to not um, do any weight training until a minimum of 3 months. Um, and that was basically his precautions or protocol that we were given.
Interesting. How long was
Yeah.
he in the boot for?
Let me see.
I pulled up his chart. I believe since February, so mid-February to May, he was in a cam.
Hmm. And does does a 6 month restriction and the 3 month restriction include the time in the boot?
Yes, yeah.
Oh, okay. I guess that maybe, I mean, because obviously you got to get out of the boot before you can do any jumping or
Mhm.
lifting.
Well, right. But I thought
Yeah.
it was interesting because for, kind of a sesamoid fracture and contusion and a little ligament tearing, I definitely didn't think it'd be this conservative of care.
It's very
But-
conservative.
Yeah.
That's exceptionally conservative, I think. I mean, I'd be curious to see what their thought process in on that is. Is it just, them being cautious, or is there some actual, data, some sort of protocol that, I'm just not aware of. I tend to think I have a pretty good feel for a lot of what goes on with the foot and ankle and whatnot, but, I'm not a surgeon, so I don't exactly know all the ins and outs of what they're looking at from a structural perspective when something like that has happened. So be interesting to kind of get their opinion on that. But cool. Yeah,
So going off of this,
Yeah.
because during the eval, I was having some trouble with his subtalar joint line, like looking for eversion and inversion.
okay.
He's a bigger guy, so trying to stabilize everything was kind of challenging for me. Is there any so I was doing it in supine off the table.
Mhm.
Is there any other technique that or repositioning I could do to get a better grip on it?
I mean, if he's just got a big, thick foot, you might do better just trying to break it down into the individual components. So the anterior component or the posterior component, because you can spend a little more effort trying to get the patient to be in a position where you can do it. Now, from a perspective of positioning it, you can have them help you a little bit with the positioning. If you take just any type of TheraBand, put it around the forefoot, and they can lift it up into dorsiflexion a bit for you, that's going to free up your other hand, not have to hold them into dorsiflexion. When they're in that position, we talked about the idea is it's going to help you lock up the talus inside the mortise. So if we can fixate the talus with the mortise effectively by them kind of passively pulling the foot toward a dorsiflex position, it frees up both your hands. Now you can kind of start doing, pushing into a medial glide for the anterior compartment here and pushing toward a lateral glide for the posterior compartment with the opposite hand. And that'll give you even maybe a little bit better feel for potentially on somebody with big joint, big subtalar region. Might give you a better feel for what the infeel is like, what the joint plane is, those sort of things. Because you could just be dealing with a situation where their joint plane is a little different than, it's a little anomalous compared to what we see. We talked about it usually being 30 to 35 degrees offset from the sagittal plane. Well, theirs could be 20 or 15, or it could be greater. It could be 40 or 45. And so you're playing with it in a plane that's expected, but maybe their particular joint plane is, angled a little bit differently.
Yeah, and that'll dictate sometimes if they're more supinated or more pronated. And also it's how you're doing it. You're doing an inversion, eversion rock of your wrist, or you like somebody that big, I would load up across the bed and try and stabilize and go with a more long lever through my forearm. So I'd be pushing straight through my forearm, or in this manner, trying to isolate it. Most people, I will use radial ulnar deviation because it's fast and easy for me. But somebody that big, am I just not going to get the feel of it that way? Do I need to get a little bit more of a compression? So maybe I come in like this and then I rock my angle, pushing through my arm where I have a little bit more control of it. And it's, for me, it's easier to feel the posterior joint than the anterior joint that way, but you can get the anterior joint that way as well.
Yeah. And the other thing is, where I'm talking about the joint plane in relationship to the sagittal plane of the body. We talked about this with the tib fib joint, is that some people's tib fib joints are very planar and they just kind of slide back and forth like this. And then others
Yeah.
are more curved like that, right? And so it's more of this sort of moment. The subtalar, there's no reason that the subtalar joint can't have the same thing, where maybe the anterior concavity of the calcaneus is just deeper compared to what you would get in kind of the average person, right? So, instead of it being kind of flat, like, of course, I can't position my hand very well for this. Instead of it being flatter like this, it's more cupped like that. And so that requires more of that kind of rocking motion as opposed to more of a translatory motion. What does that mean for you as far as trying to mobilize or mobility test it? Is you got to have more of kind of that vector toward the plantar surface of the foot. Any one of those little variations can cause, your infields to just feel weird or just to feel like you're not getting a good appreciation of what it's actually doing.
Mhm. Yeah, and again, varies between people. I don't know what one ankle is till I feel both ankles. Some people will just naturally have a more stiff subtalar joint. So I'll feel both of them and I'll say, okay, this is kind of a matching set. Then I'm more inclined to think, okay, this is maybe just the way they are set up. And oftentimes it'll just be subtle. Yeah, both your subtalar joints are stiffer than the last person I saw, but this one is more stiff than the other.
Yeah.
And
So
again,
a lot of little things. A lot of little things you can try out to see if you can, get a better feel for what it's doing. And once you have a real good idea, like if it is a joint plane issue or a joint, kind of that depth issue, things like that. Once you have a feel for that, then it can help you with the treatment mechanisms as well. It gives you a better feel for how you have to, kind of change your vector to get a good angle at it.
that's what I think with him is doing something like that. Is it okay? This person's so big and I can't get a vector. Do I try to align? So I know what I want to do with the joint. Do I align him in side lying and block it? So I can now push straight down the bed if I block it correctly and get inversion or eversion that way. Much, kind of like you would manipulate it in a sense to
Yeah,
check the
like
joint glide if you're having a hard time isolating it.
yeah, it's
Okay.
like the way we did the posterior compartment where you block off the talus with the towel and turn it sideways so you're pushing down as opposed to trying to kind of swing across. Yeah, you can do that too. You can kind of take any of the what would you call them? Theories, that sort of thing on how to approach a joint and kind of change it to fit your needs depending on the person that's laying on the bed in front of you. So
Kind of
Perfect. Appreciate
where
it.
we're going next with it is that idea that, okay, once I understand the joint biomechanics, then you can start to go off the board. If you go off the board and do it willy-nilly starting out, then you don't get clear guidelines of where do I start from and then where do I move. So you have these individuals, and it's like, okay, well, I know what this joint should feel like. It's a subtalar joint. In my mind, I got this picture of the posterior joint being convex and having this type of motion. How can I set the joint up and feel that? How do I do it in side lying, left side lying, right side lying? How do I do it, prone or in different things? So I want to picture the joint. And then once I get a real clear picture of, how this joint moves and I can feel it, then I can start to do it in different mechanisms and ways. So I don't know about you, Eric. Sometimes when you go to teach this, it's like there's so many varying ways I do it and habits I form. When I go to teach, I got to kind of review, okay, what's the baseline level to do it? So I teach it the correct way first off, and you don't get, Dave's bastardized version of it.
Well, I mean, I think personally, I think when you're in the clinic and you're playing around with these things, especially when you're learning it, is you have to do a little experimentation with how you're performing these techniques because I know for myself when I was taught them and it's just like this is how you do it and there wasn't always great feedback and we certainly didn't have these calls and there wasn't video and all that sort of stuff for us to review. It was just kind of look at the description on a piece of paper and figure it out. So when you do that, and you kind of just have to figure out what you're doing and how things work best for you. How do you fixate? How do you mobilize? How do you do these different things? Um, it gives you a certain sense of if I do this correctly. I mean, I always think about when I was doing a complex cervical spine manip, C2-3 manip from below, right? So I'm actually manipping C3 up underneath C2 because there might be an irritable segment down below that I don't want to push down into. I had the hardest time doing it with my left hand. Like, so treating somebody's left side when I had to use this left hand to do it, I couldn't get it. I couldn't get the speed right. I couldn't get the rhythm of it right. It just was confounding to me, right? This is like, that people being able to do the thing with their lip and like I can't do it on one side of my body. Physically can't make my lip do that on one side of the body. And I started thinking this is the same thing. I physically can't make my body perform this manipulation with my left hand. And eventually I kind of started doing this thing where I'd start kind of rocking my shoulder to the side. And I realized if I just leaned slightly and then produced the manipulation, I could do it just fine. So it was just like there was this little tick that I had in my own body mechanics and my own physical capabilities in performing this technique that I had to just toy around with for, several. I mean, at the time I was studying for an exam, so I messed with it for hours a day, just trying to figure out what the hell I was doing with this thing and how to get it right. Um, but once you find something that's just like, hey, you know what? If I do this, if I change this thing, if I do the change this handhold just a little bit, if I put my pressure in this different spot just a little bit more, I seem to get much better success out of it. That's the nature of being, a good clinician because it's self-evaluative, right? You have this kind of self-assessment on how do I do these things, and am I getting things done the way that they need to be done so that I get the result that I need with the patient when they come into the clinic? Because it's one thing to think like, well, if I do this technique poorly during an exam, I'm not going to do well in my exam. You guys have an exam every day. When somebody walks in the clinic and asks you for help, right, and says, I have this problem, can you help me fix it? That's the more important exam is being able to use it in the clinic, right? So when you figure these little things out, and you will, if you're willing to, kind of self-assess yourself and look at it from a, introspective point of view and figure out the different things that you need to do to be effective with it. So, and this is a total tangent and maybe a little bit of a soapbox on the whole thing, but the idea is that we can show you the technique and we can show you what the kind of the quote unquote normalized version of that technique looks like. But your technique, the final technique that you do, that you use with your patients may look a little bit different. And it may have to, I mean, um, certainly body size comparatively to the patient that's in front of you plays a role. It's going to be different for me to treat a patient that's 300 pounds than it is for Kay to treat a patient that's 300 pounds, just because I'm a bigger person than she is, right? And so those sort of things do come into play, right? I mean, unfortunately, it's just the nature of human existence. We're all a little bit different. So figuring that stuff out for yourself really helps, I think, it just helps with you understanding things better, right? And because you can take what you know about the anatomy, about the biomechanics, about the physiology of things, and you can tweak the little things that we've shown you and kind of make it your own technique. It doesn't necessarily mean we're recommending right off the bat, totally deconstructing a technique. Yeah, where's Austin on here? Is he on here? He was telling me all about that earlier this weekend.
Oh yeah,
That he
that's
likes to
totally an
deconstruct
Austin
things
thing.
and make them his own. Not the best idea to do that right off the bat, right? Because you got to have the certain understanding of what we're trying to accomplish first. But
Mhm.
it's not a bad thing to do over time. It's just kind of take it and make these
Mhm.
little tweaks and kind of alter things a little bit here and there to make them, more effective for the way that you do things. So
Yeah.
anyway, not to be off on
Oh,
too much of a tangent. Um, Lizzie sounds like she's got something pretty interesting coming in. So exertional compartment syndrome. That's an unusual one to get. It's of the posterior compartment on the actual calf.
I'm not entirely sure. So this patient found me via kind of my peripheral nerve work, just like reading kind of what's out there, but then also she is an amateur dancer that trains under one of my professionals. So
Okay.
they asked if I would look at her today and kind of go through her history. So I have about 40 pages of past medical history regarding these calves of doctors who won't listen and therapists who are a little bit out of their league. Um, and
I wouldn't even open those, to be honest.
I haven't
yeah.
yet. And she wants to get looked at as to like who can I potentially send her to, or if there's something therapy wise that we can do that's maybe different than what she's had before. But
Yeah.
when she called me just to talk to me a little bit, she starts dancing. She does ballet. After about 20 minutes, her feet go numb. Um, so she has some other kind of funky presentation. I'm trying not to go in with a bias one way or another, but also after our weekend have just been thinking more and more about like, okay, what will I assess now that's different than had I gotten this patient 2 weeks prior to our course. And before just, knowing my referrals and the people I work closely with and what does that look like? Can I, make a change and be different than where I was, 2 weeks ago?
Yeah, I mean, it's an interesting thought. I mean, I guess obviously it's going to depend on what you end up seeing when they get there. Is it really a calf issue? I mean, that's a totally different story than if it's the anterior compartment, which is kind of where you typically see compartment syndrome because it's an enclosed space. Any type of change in the pressure gradient in that space is usually what's, elicits these symptoms. So that'll be, I mean, we could go through the possibilities of either one, but I mean, that'll totally change the way the whole thing goes. I would say probably the thing that I would most likely take a look at is that tip fib mechanism. Does that change positional fault there, some sort of subluxation of the fibular head or something like that? Does that alter kind of that tensegrity of the interosseous membrane, and does that alter the ability of that particular compartment? I'm thinking mostly of the anterior compartment with this. Does that alter the ability of those tissues to withstand any type of change in pressure? Because if it's exertional, it's just like, well, what's happening with this tissue during exertion that's creating this alteration in pressure within the compartment? So that'd be one of the first things I'd look at. I mean, it's obviously, like I said, if it's, more the dorsal surface of the foot, things like that, where we're looking more at, the idea of a peroneal nerve issue versus a tibial issue that might affect more the plantar surface and the heel. It's just like, well, that really changes things and kind of what you have to think about. Because if it's posterior compartment stuff, it's more calf related. Then I'm leaning more towards the talocrural joint. I'm leaning more towards potential mortise issues, things of that sort of nature. I mean, it's like I said, it could be all over the map with it. It's just an interesting presentation, I suppose. Whatever it ends up being.
That's what's nice about it is for me, I always want to know the lay of the land. Like, what are all these joints giving me? Do I have enough motion? Do I have too much motion? Or is it just right? And then coming up the chain, because I have something that's a little bit off, and I certainly want to tweak it. If I have something that's hypermobile, then I gotta look for, okay, where am I overstabilizing? What's the impact of that? And that kind of gets me to, if everything seems like it's moving appropriately, I'm totally okay with it. I just need to know I need to go fishing somewhere else, whether it's in the neuromotor system or the mechanics or moving up to the hip. I mean, if she's a dancer, is she generating the power from where she should be generating it from? Or is it ankle driven? She a lot of power coming from the hips, or is he generating it just from the ankle alone?
Yeah, and that's what I was thinking is, with the numbness component, it's just like, is this a double crush issue where you're getting, some sort of guillotine type lesion in the lower back because of a hyperextension issue there? That tends to be a real big problem with dancers and whatnot, just because of the flexibility component that's involved there. Then, you may be getting a secondary compression point along the fibular head if it is a peroneal nerve issue. That's just like, well, that makes you kind of move up and down the chain a little bit here as far as figuring things out. But yeah, that's a fun one. Good luck with that.
Yeah, I mean, that's where you'll look different, is moving up and down the chain, saying, listen, we just need to know the lay of the land. I want to understand like your lumbar spine, your hip, how your loading mechanisms. Looking at the joints alone is usually enough. Because I mean, when I look at somebody somebody else looked at them, they never look at the ankle the way I look at the ankle. Like, how is this compared to what you did before? They're like, this is completely different. No one's ever looked at me like this. And all I'm doing is what I normally do.
Yeah.
So it's like, hmm?
I get that a lot.
Yes. Yeah, so it's not a real, once you learn this, it's not a real high bar. For you, it's what's normal. It's like they don't look at these things. For me, I'm always stunned. Like, no one has ever looked at it this way. So it's a nice system to get the lay of the land, and that's a complete part of it. It's the biomechanics of it, but it doesn't come down to not manipulate. I'm not going to manipulate it, so all this stuff doesn't matter. It's like, no, I need to know what's happening in time and space, and what is this joint doing, and also in time and space. So what is impacting the biomechanics? Is the ankle collapsing too much at 10 or 15 minutes? Is there a mechanic that changes when she hits that time period? What I want to see. If there's something going on that changes at that time period, maybe she starts losing hip control or something in the lumbar spine. Now the system's collapsing and she's loading through the ankle more. There's, what is the variable there? Once I understand the biomechanics. So the biomechanics is really that starting platform to kind of move from.
Thanks. That's helpful. Hopefully it goes well. Stay tuned.
And be okay to say, hey, listen, sometimes, I'm going to go here and set up what you're going to do next session. Hey, next time we're going to look a little more proximally. And then I need to look at what you're doing endurance wise. So, I would definitely, with most of your patients, set up what am I doing today? What am I going to do next time? Here are the pathways that I'll need to go down to get the complete picture. If I don't see it in the first session, the second session, this is what we're looking at in the third session. It's going to take time to work through this because you've been through a lot. So that'll also get you buy-in so she doesn't quit on you because she's gone through multiple people. So she'll be looking to quit pretty quickly if she feels like you're not doing anything different. So set up the system that way. That way you get buy-in sometimes so you get enough time to figure it out. I think sometimes with complicated cases, they'll burn out on you if you don't set up the plan of care to do it. Of what am I going to do this session? What am I going to do next session? It's super important in getting that buy-in.
Yeah, I feel like they also burn out when they've seen so many other therapists in the past. Like they're already coming
Yes.
with a therapy
Mhm.
doesn't work kind of situation.
Yeah. You get that,
Yeah, and
get that a
yeah.
lot.
So that's why kind of mapping out, having this knowledge and showing, wow, this exam is different, and then laying out where you're going to go is you need to, build rapport and they have to have confidence in you. So it's using these techniques. One of the most powerful things you'll do is build rapport, gain confidence with how you evaluate them. That patient buys in. It also buys you enough time to get to the third session, and all of a sudden it's like, boom, you put it all together.
Yeah.
You don't feel like I have to get it all in 30 minutes. It's like that you're building toward I can get it all today, but I feel like I got a beat on it. And that second or third session is like, boom, there it is. Now I see the entire picture. So go easy on yourself a little bit. But if you build rapport, get buy-in, tell them where you're going, what we're going to do next session that's the same, what will be different, they will keep them along till you figure it out. And you will probably most likely figure it out.
Yeah. I mean, it's always a bit of a process. I mean, sometimes you get lucky and you find something right away and it gives them great relief. I mean, my suspicion is that this person's also dealing with some issues elsewhere that, certainly you can ask about. They might have a little bit of ankle discomfort, they might have a little bit of heel discomfort or something else that's going on that's not just this
Mhm.
whatever comes along with this compartment syndrome that they're dealing with. Um, and that gives you clues because essentially if they say like, oh yeah, by the way, I'm also having, first MTP pain with this as well. It's not just the numbness, it's also this. It's just like, well, we should be able to help you load that more effectively and, kind of help to alleviate some of that pain. Maybe it's metatarsalgia, that forefoot pain, things of that sort of nature. You can help them unload that stuff. And if you can even just get some of the stuff to change, right? It doesn't have to be completely gone, but if you improve it, if there's something that you can find that you can help improve, that helps with that buy-in right
Mhm.
away, right? Being able to show somebody and say like, well, look at how this moves, say it's the talocrural joint, and you're just like, well, look at how much, motion you get here on this leg, and then look how little you're getting on this other leg, and then you're able to do something to help improve it, and kind of show them the difference from the beginning of the session to the end of the session. That is one of the best buy-in things that you can give somebody, right? Is just like, yeah, look at this. I mean, we could change this in 10 minutes. Imagine what we can do with 3 weeks. So that's a big deal, especially in patients like that, because I get a lot of those too, where I get, a referral from another physical therapist that was just like, I have no idea what I'm doing here. I spent all this time doing these things. It didn't change a thing. The patient's frustrated, so I send them over to you so you can figure it out. And it's just like, great. Now I got this person that's coming in and they're going to have their hand on a hair trigger here to just be like, this, nothing, none of this is working. I'm out of here. And, so you gotta find something early on in those sort of scenarios to kind of set the hook, so to speak, where you show the patient that, hey, there's other things that can be done here. There's other ways of looking at this stuff. Um, and you like to hope that you have a different perspective than what they've already had done. And that's probably something I would ask during the subjective portion of my eval is just like, so, you've seen X month, this person, this person, this person. What is it that they've tried previously? Because then if they're going to say something that maybe was on your mind, you probably don't want to recycle something that another therapist has done and kind of, quote unquote,
Mhm.
failed with. So, you have to be able to kind of pivot your thought process if they're saying like, oh, well, they worked on whatever, so they worked on this and you're thinking of, maybe looking at that, you might have to say, well, I might still look at it because maybe this other person doesn't look at it the same way. They don't know the mechanics as well as you do at this point. So maybe it's still worth looking at, but you don't necessarily tell them, hey, we're going right here. You're just going to take a look at it and see what it does. What was it? Somebody was telling me something about it, about one of the joints in the foot over the weekend. It was something about this, I think it was something about the subtalar joint. Jacob, was it you that was telling me about this is how we used to do it, and we do this mobilization or do this mobility test going this way? And I'm like, well, but that you're only using one. You're not breaking it up into the bicondylar mechanism here, and so you end up that might have been what it was. So
That
it's
was
just
that
was
was
that
you.
you?
Yeah, yeah.
Okay. Yeah, so but that's kind of the idea, right? It's just like, well, here's how I was taught to do it originally. And when you look at it and you say, okay, this is how it really should be tested because of the anatomy of it and the biomechanics of how that anatomy works. It's just like, well, if you do it this way, the way that you were originally shown, you're going to end up getting this, really unsatisfying feel to it because you're kind of just pounding the joints into the articular surfaces into each other. Nothing changes. So it doesn't give you a good feel. So yeah, I mean, even if somebody's looked at something that you're thinking of, you can revisit it. You just probably want to kind of keep your eyes on making sure you have something else to tell the patient so that it's not a recycled idea that they've already had no success with.
One more thing for this patient.
Sure.
She has scoliosis. Would I change really anything?
Because of the scoliosis?
Yeah.
I wouldn't. I mean, it would depend on how severe it is, obviously. I mean, a real severe scoliosis is just like, yeah, okay. Their mechanical loading is going to be, and there it is again, Apple software every week. If they have a significant enough scoliosis, then their loading processes are going to be different than average anyway, right? And so there's some considerations to be taken there. The one thing that I will mention about patients that have kind of, relatively mild scoliosis is I always have this little bit of doubt, this little bit of doubt in my mind that is this a fixated thing? Is this how they've always been? Or is this an acquired issue that they've developed as a result of some sort of thoracic ring lesion or something of that nature, right? Because we can get little deviations in the spine, we can alter the curvature. So say we get a ring lesion, we get a left shift of one of the rings, right? Well, so when we do that, we're gonna get these kind of rotations of the ribs that changes the length tension relationship of some of the long thoracic paraspinals. As those long thoracic paraspinals contract and get more and more tone associated with them, just because they're being pulled tight by this kind of twist through the rib cage, that can create a mild scoliotic curve, right? We see it with the QL at times where, you get a 11th rib subluxation or some sort of 11th rib lesion, and the QL suddenly gets hypertonic and it starts pinching down. Now we've got this little curvature through the lumbar spine, which is why when you look at, how a lot of chiropractors, and again, I don't want to impugn an entire profession, even though I do want to impugn them, I'm not going to. When you look at a static image like an X-ray that they might take during, their initial session, it's just like, well, yeah, their spine is resting in this position, but does that mean that it can't get out of that position? Right? Somebody that has a true, anatomical scoliosis, they have a hard time getting out of the position that they're fixated in. If it's this more change in motor tone stuff, if we correct the dysfunction that created the alteration in that length tension relationship, they can very easily get out of that position, right? So it's more about not just where they're sitting, not where their resting position is, but can they get into and out of the various ranges of motion that they need in order to be functional. So little things like that with the scoliosis, again, barring it being a very substantial curvature, you got to kind of keep in the back of your mind because could there be a situation where a mid-thoracic issue is affecting portions of the lumbar spine that's creating one of these, like I mentioned, a guillotine lesion or a partial compression, mild compression of one of the nerve roots, and then we're getting a secondary tension point down at the fibular head, and that's actually what's causing the numbness, as opposed to it being a true compartment syndrome. You could be looking at a scenario like that, and that's exactly the type of different perspective that a patient that's gone through multiple other treatment avenues is looking for. They're looking for somebody to come up with something that's different, something that still has a chance of providing some relief. So, I mean, this is right up your alley, Dave, talking about the, stuff coming down from above.
Yeah. Yeah, that's where it is you're unique, and it's good to understand that right now. This is a perfect time to talk about not only the techniques then to look at these other body parts, start setting up your plan of care, leverage the knowledge that you have for buy-in and rapport. It's going to allow you to want to get you a little more time to really fix things. Because I mean, problem you'll run into is like, well, Eric, I mean, cash-based practice, especially like once you fix their pain, they want to be done. It's like, okay, I'm good, but they need to understand that you need the retraining component of it too. The neuromotor system needs to be reset. You want to retrain them. So you get that buy-in and rapport. They understand that, hey, this happened to you. This is why it's happening to you. We need to work on this other component that's the primary driver. Like this is the way you're moving that's doing it. This is what needs to be changed.
Okay.
That takes time and reps.
Yeah. Yep.
So
Yeah, it's
you just
interesting
make sure,
stuff.
like once I figure it out, Lizzie with her, so once we figure it out, then the hard part's going to be grooving the new pattern.
Yeah, for sure. This is kind of exactly the type of session that I was hoping to have today, where you guys actually had some things that you saw based on the technique stuff that we did over the course of the weekend, so that we could kind of talk about how it relates to real life, when you're seeing somebody walk in the clinic. So this has been good. I did have a couple of cases that I had thought about going through, and we can still maybe even do that next week. I think we've probably got another week or so before we have to start
Yeah.
leaning into module 5.
I think it'd be good to really get some route. It's a good time to really get some pull through on this. So, getting in the cases and doing that. I'll sort out some of the module 5, start kicking out some of the information from that. I'll sort it out and get it opened up this weekend for you. I'll kick an email out, just to let you know where it is. But, probably getting out some of these cases and really kind of getting your mind thinking about different ways and where to go with this. But as a whole practitioner, it's a great time now because I mean, really, it's like probably 80% of the techniques, but the really cool
Yeah.
stuff is probably ahead.
Yeah, I mean, the SI joint, there's a lot there in
Yeah.
module 5, and kind of how that interacts with the thorax and the pelvis, and not just the pelvis,
Mhm.
lumbar spine and the hip and all that sort of
Mhm.
stuff. We've got to clean up the knee and the hip a little bit. I think we'll probably
Yeah.
just go ahead and get that done on Friday when we get into it. But um, yeah, I mean, technique wise, there's just not as many techniques to deal with, right? So it'll be good. But yeah, we can kind of go through some more case stuff, either stuff that you guys bring in, or I have a couple we can kind of walk through as well. Next week, I think that'll be another good way to kind of help, tie in some of these, how do these techniques fit into the practice, right? And that's kind of the way we want to
Yeah,
talk
I
about
really was just the start really starts feeling it. I really start to kind of feel like you're pulling strings together. And that Friday is so key and getting that last little bit that's missing. That piece, like what Eric talked about, practicing that for hours because he was missing that one small piece. Fridays and their time together is all about that. Write down the things like that you feel like, man, I just don't get this one thing. You're probably just a little bit off. You're not a lot off. It's just a little bit from making that aha moment occur. So when you get those things with these techniques, write them down, bring them on that Friday on the weekend. Between, Patrick, the other fellows, we'll be able to sort it out for you and help you out with that learning curve. So you're not like Eric spending 5, 6 hours realizing, I adjust my hips a little bit and this whole thing works.
Yeah, and that's the thing, because we're gonna always do a little bit of review anyway, so but if you guys have things that you want to review specifically, I can make a list out and we can kind of go through stuff that I just throw at you. But certainly if there's stuff that you guys feel like, I'm just not getting this, and I don't know how this fits into what we're trying to do, we can certainly go through that stuff. We all know I'm not afraid to go off on a nice 40-minute tangent about how to deal with ring lesions in the thorax again, even though we've already done the class. So now, pretty good stuff though. I'm glad you guys are looking at the things, getting your hands dirty here with that stuff, and we'll keep it up again next week, I think.
All right. Good stuff.
All right,
All
guys.
right, everybody. Enjoy the rest of your week.
Talk to you then.